Good afternoon, ladies and gentlemen. Welcome to our seminar, Journey of Hope. Today, we're very fortunate to have two wonderful presenters on this topic and also a panel of patient advocates. And today, as you know, we have a live webcast audience which is viewing the presentation. Many are from the region in India or China, but of course worldwide. And this recording will be available after the live webcast, so any who missed it can go back and review the presentations given. My name is Bill Claxton. I'm the president of CNETS, that's the Carcinoid Neuroendocrine Tumor Society here in Singapore. We look after patients who have this neuroendocrine tumors, NETs. And today we're presenting or co-organizing jointly with two other groups, the PatientsEngage group and the 365 Cancer Prevention Society. So I have a few opening remarks, but let me just share with you the agenda for today. So we're going to have a presentation by Dr. Shan Yang on nuclear medicine is more than just PET scans. And he will kind of set the stage for us to understand the advances in nuclear medicine and how they apply to various cancers, not only neuroendocrine tumor, but prostate and others. And also he has a good sense of the clinical picture, what's happening in the picture, in the clinical environment, the caseloads, and so on. Second, we'll have a presentation on more from the laboratory perspective, how this targeted radiotherapy is being researched and developed for application to other types of cancers, whether lung cancer or other cancers can be targeted in a similar way. And then we will have our panel discussion. Aparna Mittal is joining me from PatientsEngage, and Andrew So is joining me from the 365 CPS, is the short form, Cancer Prevention Society. So in my opening remarks, what I want to say is that as a patient myself for nearly 20 years, I've seen a lot of the development of treatments for this rare cancer. And to contextualize it for those who are not affected themselves or in their family by neuroendocrine, let me start with this bit of background. Sometime in the 90s, maybe a little earlier, people in the medical field started looking at how to put radioisotope into the bloodstream and target specific tumors. And in order to do this, they need markers, or I should say receptors on the tumors that will pick up something and have a binding affinity to some sort of protein or peptide. And so there was research done in the area of what sort of binding peptides and proteins can be targeted in various different types of tumors. And then secondarily, how you can tag these with radioisotope to do imaging so that you can see inside the human body where the tumors exist and so that you can target them. A lot of work was done over a period of 20 years, and sometime around the turn of the century, it was realized that for this specific narrow group of neuroendocrine tumor patients, they could use the peptide related to somatostatin, and they could bind with radioisotope and do either imaging or targeted therapy. So when I was first diagnosed, this was just emerging to the marketplace. And in fact, in this group of patients, you can see me in the center there. This is in Rotterdam, in the Netherlands. We were amongst the cohort of the first 300 patients to receive this targeted therapy in the world. And it's a very effective therapy. And what you're going to hear about today is how this therapy is applied across many different cancers and what it can bring to the cancer community, both the clinical side as well as the patient side. And for me, this is just a tremendous breakthrough that we can now start to talk openly about targeted therapies using radioisotopes for a range of different cancers. In fact, my personal experience as a patient is that this is one of the most active areas of research and development in all of medicine, is this targeting of tumors and lesions with radiotherapy. So with that, let me give it over to Dr. Yan for his presentation. Dr. Yan is a senior consultant physician with Singapore General Hospital and visiting consultant with the National Cancer Center of Singapore. He obtained his medical degree from China, completed medical training in USA, and fortunate for us, migrated to Singapore to practice 5 years ago. He is also the head of the Nuclear Medicine Society of Singapore. So without further ado, introduce Dr. Yan.
Thank you for your kind introduction, Bill. Ladies and gentlemen, good afternoon. I'm Sean Yan. I'm the president of the Nuclear Medicine Society in Singapore, and I practice nuclear medicine on this campus in Singapore General Hospital. I think it's a great honor to be here. I have known Bill for many years, but I have never had personal interaction with him. But I always admire the aspiration of your society and the contribution you have made to our patients. So actually, when you invited me to participate, I feel very privileged and excited. But I never realized how tough is a mission. Then later on, I realized that the audience actually is very diversified. We got patients, we got caregivers, patient advocates, and also some general practitioners. I'm not sure how can I make everybody understand what I'm trying to say. So please interrupt me anytime if some concepts or terms have confused you. So my talk is nuclear medicine is more than just PET scans. So how many of you have had a nuclear medicine procedure in your life? Raise your hand. You are, of course. Okay. How many of you have ever heard of this specialty, nuclear medicine? Say, some of you. Okay. So nuclear medicine, I think, at first place, probably sounds quite scary. There is something nuclear, something atomic. So what is it? It is actually a specialty of medicine, which uses radioactive substance in diagnosis and therapy. In United States, there is an organization, it's called American Medical Specialty Board, which covers all the medical specialties. There are about 33 specialties under AMSP, and nuclear medicine is one of them. And of course, nuclear medicine is one of the small specialties in medicine. So those radioactive substances, they consist of pharmaceuticals. Some type of pharmaceuticals is a molecule or chemical. They're labeled with radioisotope, which is radioactive. Yeah. Then the product we call radiopharmaceutical. Here is the example, the sodium. The sodium is labeled with iodine 131, makes iodine 131 sodium iodine. That is the medicine. That is a radiopharmaceutical we use to treat thyroid conditions. So for diagnosis, usually the radiopharmaceuticals are administered either orally or by injection or by other method. Then the radiation emitted is located and recorded by a device, for example, a PET scanner. A PET scanner right here in the picture. So the PET scanner is positron emission tomography. It's not a scanner to scan your pet or the pet in your household. We just gave this abbreviation, PET scanner, to make it easier for everybody. So for therapy, radiopharmaceuticals stay in the diseased location, and the radiation will kill the diseased cells at that location. So we inject the radiopharmaceutical, then it goes to where the tumors are and kill the tumors. It's very different from what we call external radiation therapy, which we use a device that can produce a radiation. The produced radiation will shine on the patient and kill the tumors. So fundamentally, there is difference in the mechanism of these two types of radioactive treatment. So is it something related to nuclear bomb? I think the answer probably is yes. Yeah, nuclear medicine and nuclear bomb both use radioactive materials or substance. However, nuclear bomb use it in a large quantity and in an explosive way to kill people or to destroy the world. And the nuclear medicine use the radioactive material in a small quantity and a targeted way to save the people, to save people's life. Yeah. So that's a relation, and also that's a difference. So in this world, there is an organization, it's called International Atomic Energy Association, which is a branch under United Nations and headquartered in Vienna, Austria. Yeah, this is a body governing, advising, and guiding the practice of energy, atomic energy, to guiding using atomic energy in all kinds of fields, including the human health. So there is a division called the human health, and under this division, there is a section it's called nuclear medicine. And this section was previously headed by Dr. Ajit Kumar Hadi. He is my former colleague, and he later on left this section and joined the Singapore General Hospital to practice nuclear medicine. And a counterpart, corresponding counterpart of IAEA in a national level in Singapore is this ministry, National Environmental Agency. So how sophisticated is nuclear medicine? Because nuclear medicine is small, and not everybody, have contact with this small specialty every day. So many patients or even caregivers probably are not familiar with this specialty. So actually, nuclear medicine has many applications. For example, it can be applied to cardiology, which is a medicine for your heart. And you use a special heart radio tracer. You can detect the ischemia in your heart and predict who is in the risk of getting heart attack. Yeah, this is called nuclear cardiology. You can also use a tracer to image in your brain and find who is in the development of Alzheimer's disease. So you may give the patient early intervention to stop or slow down the process. Sometimes we can use nuclear medicine to image in the brain blood flow. If we say there is no blood flow in the brain parenchyma, we call the patient already brain dead. Why you want to know if the patient is already brain dead? Because if you know this at the right time, at the early time, you can harvest these dead patients' organs for transplant to save other people's life. So this is what we sometimes we do on a daily basis. So this is called nuclear neurology, which is nuclear medicine application in the brain and the nervous system. Yeah. But of course, more commonly, nuclear medicine's application is in oncology, which is in cancer or in tumor science. Yeah. So we use this PET scanner to see where are the tumors, yeah, and how bad the tumors are. So for example, we can say this patient has a thyroid tumor, which has metastasized to the liver and the bone. Then we know the patient is at end stage. Yeah, he probably needs a systemic treatment because the disease is already everywhere. So sometimes when you have when you have a diagnosis of cancer and you had a scan of CT scan or MRI scan, your doctor's still not sure, the staging of your disease or the overall picture of your condition. They may tell you, okay, I think you need a more advanced scan, a more sophisticated scan, which is PET scan. Yeah. So by doing a PET scan, we know the disease, we know the tumors more exactly, and we know, so we can plan the treatment more precisely. So you see the tumor, of course you want to treat the tumor. This is what we call, we see what we could treat, and we treat what we see. Put together, it's diagnosis and therapy. Put together, it's called theranostics. So now every year on March 31st, we have a World Theranostic Day. We, as a professional, we always celebrate this day. March 31st is designated as a Theranostic Day because 1941, on this particular day, Dr. Shaw Hertz, who is a doctor in Massachusetts General Hospital in Boston, gave the radioactive iodine to the first thyroid patient and treated the patient and almost cured the patient disease. So this is the first practice of using radioactive material to treat the patient. Since then, this concept, the theranostic concept, has been, spreaded in other conditions or other fields, like Bill just mentioned. In 1994, a treatment is called PRRT, is developed for the condition of neuroendocrine tumor by a group of doctors in Erasmus Medical Center in Rotterdam. This past summer, actually, I went there just to salute the pioneers in that hospital. Yeah, it's a fantastic trip. And recently, in 2021, the PSMA, which is for prostate cancer, was also approved. But the classical example is using radioactive iodine to treat thyroid disease, because in the thyroid, the follicular thyroid cells, they will take up radioactive material, and the radiation will kill the cancer cell or even the gland. So then why you do the radioactive iodine for thyroid cancer? Because the research has demonstrated the patient after surgery, if they get radioactive iodine treatment, their modality, disease-specific modality, decreased by 2/3. They live longer, they live better, and they live more happily. Yeah. Another radioactive material, substance is called white-light microsphere. You see those spheres, they were labeled by yttrium-90. If we inject those spheres into the vessel, and those spheres may go to the tumor and kill the liver cancers. It can be for palliation or adjuvant treatment, or sometimes for cure. So this is one of my patients who had a liver cancer, which is a very common cancer and very with high modality. So he had a cancer in the right liver lobe and had a surgical resection, had a lobectomy. But 2 years after, the cancer came back at here. This is a location is not good for surgeons. It's very difficult to operate. And also, it's a location difficult for interventional radiologists because it's very deep. They can't reach here to burn the tumor. So we give the patient white-light microsphere, very small dose, white-light microsphere. 1 year after, 2 years after, the patient is still disease-free. Yeah, I believe that this microsphere just cured the patient, the disease. Sometimes, if the tumor is very large, not like this one small. If it's very large, then you cannot cure the patient. And if it's large enough, surgical resection is impossible. However, you can still give the patient a microsphere just to downstage or downsize the tumor. For example, this 8-centimeter tumor, 3 months after, the tumor became 5 centimeter, even smaller at 8 months, and finally came down to 4 by 5 centimeter. And this is small enough that the surgeons feel comfortable to chop it off. So the patient had a surgical resection. 1 year, 2 years, 3 years, 5 years post-resection, the patient is still happily living. Then this is what I already mentioned a little bit, somatostatin receptor-based theranostics. Because some conditions, for example, neuroendocrine tumors or carcinoid, the tumor cells, they express the somatostatin receptor on the cell surface. They have this protein on the cell surface, which can be targeted by a molecule we call somatostatin analog. Yeah. If you label this analog, you make radiopharmaceutical, it's called lutetium-177, for example, DOTA-8. Yeah, you give this medicine to patient, it will kill the neuroendocrine tumor. This is one of my patients referred from Shanghai, pancreatic primary neuroendocrine tumor with extensive metastasis all over the body, you can see. It's tumor everywhere. Because this treatment was not available in China, so the patient was referred to Singapore General Hospital for the treatment. We gave him 4 treatments. Say 22 months, 2 years after treatment, 3 years after treatment, 4 years after treatment, disease-free, complete remission. Until like 54 months after the PRRT treatment, the disease came back at the original location in the liver. And at this moment, the patient contacted me saying, hey, Dr. Yan, my disease, my tumor came back. Can you please treat me with PRRT again? Because it's so powerful. It gave me like more than 4 years disease-free time. I said, yeah, PRRT is good, but it's not suitable for every patient or at every stage or any moment. At this time, probably a local regional treatment, it's called radiofrequency ablation, is better for you. So the patient went to Shanghai and had this RFA done. He gained another about 2 years disease-free time. And in the past March of this year, on the regular routine surveillance scan, multiple recurrences were found in the body. And he called me again. He said, what should I do? I said, right now, you are a right candidate to do PRRT again. But unfortunately, it's very inconvenient for him to come here for the PRRT because after each treatment, if he went back to Shanghai, he would be quarantined for like 3 weeks. That's quite brutal for a cancer patient. So finally, he chose to do systemic treatment. I'm not sure about the current status now. Yeah. So this PRRT treatment gave this end stage metastatic patients more than 7 years, almost disease-free time. And during the 7 years, his son got married and had grandsons and granddaughter. He's very happy, very grateful. Yeah. Not just neuroendocrine tumors, because the somatostatin receptor, this protein, can be expressed by other type of cancers. For example, nasopharyngeal cancer. This is a very common disease in Singapore and in Southeastern Asia. Yeah. This particular cancer will also express somatostatin receptor and can be treated by PRRT as well. For example, this is a patient treated by my friend, Dr. Andrew Tan. The patient's primary tumor in the nasopharynx was cured by radiation. However, the cancer cells migrate to the liver, and that is going to take the patient's life. So because all treatment tried and unsuccessfully, so we decided to give the patient PRRT. Look at the tumor in the liver everywhere, yeah, everywhere. But we gave 2 treatments, lutetium dotatate. After 1 treatment, after 2 treatment, you can see the response. 3 weeks after a second lutetium dotatate treatment, we see some tumors on the left side, right here, disappear. Smaller tumor here in the right lobe also disappeared. But of course, a large tumor in right lobe actually, I think, has grown and has become a bit larger. The patient finally passed away a few months after the treatment. Although the treatment didn't save the patient's life, it does, give us some confidence and give us some hope. This is a journey of hope, right? Some hope. In some patients, this treatment may be effective and may be life-saving. Of course, for prostate cancer, which is the most common cancer in men, we developed a similar treatment, which is called PSA-RLT, radioligand therapy. It targets a particular protein, it's called PSMA, prostate specific membrane antigen, on the surface of the cell, and can can kill the tumor cells. This is a patient extensive metastasis. After one treatment, two treatments, three treatments, finally disease disappeared. Complete response. Very amazing. Before this treatment became available, such a dramatic response in an end-stage patient was very rare. So it's a striking contribution in this field and also striking benefit to our patients. This is the first patient in my department, PSMA treatment. It's a police officer. This is the pre-treatment scan, disease everywhere. After 1, 2, 3, 4 treatment, a PSA dropped like 90%, and the patient is still alive. It's 4 years after treatment. But of course, if the patient, the cancer is resistant to the particular radiation, for example, the radiation from lutetium-177, which is a beta emission, beta radiation, you can change this radioactive substance to another one. It's called actinium-225, which is alpha emitter. So can give the alpha ray, which is considered and believed the more powerful, more effective. So this patient, lutetium PSMA treatment is ineffective. Then change to actinium-225 after 2 treatments, completed response. Yeah. This new treatment is available on this campus now. Yeah. So we are offering patients actinium-225 for prostate cancer and soon for neuroendocrine tumor as well. Yeah. So finally, I want to talk about how's nuclear medicine in Singapore. In Singapore, it's a red dot, very small population, 5 million people. We got 13 PET scanners and some PET MRI scanner and about 20 SPECT scanner. That's another type of scanner. In Singapore, we got only 30 plus certified specialists. Entire country, we got only about 30 doctors. So if you don't get a nuclear medicine doctor in your friend circle, don't be disappointed. Yeah, not a huge number of the specialists in Singapore, but half of the specialists work here on this campus in Singapore General Hospital. That makes Singapore General Hospital nuclear medicine the biggest department I have ever worked with, or I have ever known of. I practiced nuclear medicine in China, in States, and here. I have never seen a nuclear medicine department with more than 10 specialists, including MD Anderson Center in Texas. It has about 10 physicians. Yeah, I worked in Vanderbilt, Mount Sinai, Emory University Hospital. Those are big medical centers, but usually they got like 5 physicians in the department. And here we got 15, actually 17, but including 3 part-time specialists. So we got 1 residency training program on this campus. Of course, it's also the only one in the country. Produce about 1 or 2 specialists every year. Our society was incorporated in 2110, and currently I'm leading this society. We do thousands of scans, all kinds of scans. We do about 1,500 therapies every year for thyroid disease, for liver cancer, for neuroendocrine tumor, prostate cancer, bone metastasis, and other conditions. Because of the advanced job we do it here, I think the nuclear medicine on this campus and also in Singapore gained some reputation. globally, and particularly in this region, in Asia, in region. So we treat patients from all over the regions in Asia. For example, we got a lot of patients from Taiwan. So every time I go to Taipei, those patients I have, treated, they still live healthily. They usually give me a reception and they just want to show me how happy they are, how healthy they still are. I think there is nothing in this world which can make me, happier than seeing my patients are living happily. Yeah. Okay. So if you want to learn more, please come to our meeting. We have a conference next February, right here in this building. Yeah. You can donate, you can participate, you can just stand by. Any participation is appreciated and is valuable for our society and also for our profession. Thank you.
Thank you very much, Dr. Yan. I have a couple quick questions for you. One is, there's a lot of buzz around the world about the new alpha therapies, the actinium-255 and other. With this treatment becoming available in Singapore for neuroendocrine tumor, what are the special steps that need to be taken at the hospital for approval of this new therapy? How does it get from the lab into the clinical setting?
You are talking about the administrative part or the technical?
No, administrative and approvals and ethics committee and all of this.
I think different countries have different protocols. In Singapore, number one, we need to convince the governing bodies, for example, the IRB and the ethical committee, that this is the treatment modality which has been in practice somewhere else. Yeah. So that is a case for actinium-225. It is published. It is in use in some European countries or Australian countries. So we have to provide this evidence. Then we have we submit the application to IRB and ethics committee to get approved. And then we need to tell HSA, we are going to do this kind of new treatment, which is still experimental. Then we will do HSA may approve, and we will do it in a highly regulated way for about 20 patients. For these first 20 patients, we collect data just to prove the safety and efficacy. Then we have to submit the application for clinical service again. Yeah.
And so, this process takes maybe, 6 months?
Maybe 1 year.
I see.
Yeah.
And is this process speeding up for more drugs or products to come to market?
If there are more evidence available, the process may be sped up. But the regulating bodies, they have their own workflow.
Right.
Yeah.
Okay. So my second question is, those patients who cannot get the benefit of such treatment. So there are exclusion criteria based on the fact that you maybe don't have the receptors, or the receptors are not strong enough. So what can you say about exclusion of patients? You do some screening based on theranostics to see whether they have uptake on their scans, and this qualifies them for the therapy. How do you sort of discriminate between those who are able to and those who are excluded?
Yeah, I think for any condition, there is no single treatment modality which is, universally effective to everybody. So we have to select the patients for a particular treatment. Talking about this, a PET scan is the most commonly used modality or method to screen the patient. We have to see the tumors first. If we can see the tumor on the PET scan, then we know we can treat. But we are still not sure about the efficacy. I mean, we are not that good at predicting the outcome in a particular patient. But at least we know this patient stands a chance.
Thank you very much, Dr. Yan.
Thank
It's
you.
a very insightful presentation.
Thank you.
Last question that I asked is to kind of get a little bit of teaser for our next presentation, which is to look at the situation for patients who maybe have pancreatic NETs, who they will be negative on these scans. And then what are the options for them? The patients may have secretions of some kind, but they are not considered as a functional tumor, and it's not easy to identify through tagging of peptide or protein. And so those present very challenging cases in the clinical setting. And our next speaker will share what's going on in the lab to provide some options for such patients. Our speaker is Professor Dr. Zhang, who was until recently a nuclear medicine physician and clinical research fellow at Centrelink Bad Berka in Germany. This is one of the world-renowned centers for theranostics. And fortunately for us, she's come to Singapore recently and joined the NUS Clinical Imaging Research Center. Please join me in welcoming Professor Dr. Zhang.
So many thanks to CNES Singapore for inviting me to give this presentation, and many thanks to Mr. Bill. I have known Mr. Bill mainly through my German supervisor, Professor Dr. Richard Baum. So dear CNES Singapore President, Mr. Bill, dear friends, ladies and gentlemen, it's a great pleasure to be presenting at this webinar, Journey of Hope, today. I'm Jingjing Zhang from the DDR Department of National University of Singapore, and also have a joint appointment in the Clinical Imaging Research Center for clinical translation of National University of Singapore, and also as a member and Dean of Research for International Centers for Precision Oncology. I have no disclosure concerning this lecture. So I shall begin with context about radionuclide theranostic for precision oncology, including the lutetium somatostatin receptor targeted PRRT and lutetium PSMA radioligand therapy, both have been as a paradigm for the radionuclide theranostics, and also move on to the advancement in theranostics, including the new roles, new indications, new ligands, as well as new radioisotopes, and also speak later about ICPO. So theranostic is a combination of a diagnostic tool and the therapeutic tool for specific disease. And it is not specific to nuclear medicine, radionuclide. However, it was first used there and also play a very important role for theranostic because radionuclide theranostic is easy to apply and to understand because of the easy switch of the radionuclide from diagnosis to therapeutic isotope. And also targeted radionuclide therapy has unique promise for personalized and precise treatment of cancer because both the targeting vehicle and the radioisotope can be tailored for individual patient. So we use this lock and key principle. We have on the tumor target as a lock. We have the, as we know, the somatostatin receptor, and also PSMA, and also tumor environment cuffs. And also we use the key to hit the locks. For example, the peptide, the PSMA small molecule, the FAP ligands, and then we have a key linker we call chelator. We can fit in the diagnostic radioisotopes such as gallium-68 for PET imaging. We can fit in the therapeutic isotopes such as lutetium or actinium and so on. So within the past, there is a faster development for radiopharmaceuticals to treat the cancer patient, especially within the 2 decades. And a brief summary about the first human studies in my previous working center, the Bad Becker in Germany, mainly led by Professor Baum. And as you can see, for many compounds like the dotatate, TOC, RGD, CXCR4, and to PSMA, and also FAP, and so on. And also we use gallium, the different isotopes. For example, gallium-68, and also yttrium-90, the lutetium-177, the bismuth-213, actinium, and terbium, and so on. So within the 2 decades, the gallium-labeled peptide for somatostatin receptor targeted imaging for PET-CT imaging, PET-MRI, and followed by the lutetium and yttrium-90 labeled, for example, TOC, has demonstrated a remarkable success in the management of neuroendocrine tumors, and also paves the way to other indications for theranostics. So because a very important neuroendocrine tumor biology is the high expression of the somatostatin receptor, and it provides a basis for the theranostic approach for imaging and also therapy, what we call PRRT. And this just to show example of a patient with well-differentiated non-functional neuroendocrine tumor. We can see a lot of liver metastases, and after 3 cycles of PRRT, there's a complete remission of the multiple liver metastases, which have already been 5 years after the treatment. And also the primary tumor has also responded well to PRRT. And this shows history of PRRT neuroendocrine tumor, as mentioned by Mr. Bill already. And also you can see many milestones, such as first treatment with yttrium-90 TOC in 1996, and also the first treatment with lutetium dotatate in 2000, and also the very famous phase 3 clinical trials with lutetium dotatate started from 2012. And also based on the very famous 91 trial, which is randomized control study in metagot neuroendocrine tumors. And the lutetium dotatate, Lutathera, got approval by both the EMA and FDA, and also got marketing authorization by the agency in Japan in 2021. So by using lutetium dotatate, we can achieve 79% reduction in the risk of disease progression and death. And what is very important is we can achieve longer progression-free survival. And also in our clinical practice, we can see a different situation for individual patients, such as for example, this is a patient who participated in the 91 trial, and during after 4 cycles of PRRT, this patient achieved a stable disease. However, after 2 years of follow-up, even delayed response, there's further remission of the disease was noted for this patient. So what about safety? So for PRRT, kidneys are generally considered as dose-limiting organs. And so my previous working center and also some other group in Italy and other group in Europe has studied a large cohort patient more than 800 patients, and also with longer follow-up. And we can see there for lutetium PRRT, there's 0% for G3 or G4 renal toxicity after lutetium PRRT. So we also analysis our single center data. We can within 20 years follow-up and more than 4,000 cycles of PRRT. We look at before the treatment and after treatment. As a result, show there's also no long-term nephrotoxicity, even after 10 or 15 years. So another paradigm is lutetium PSMA radioligand therapy. I will skip some details. As what we used for diagnosis and treatment for prostate cancer is PSMA, prostate-specific membrane antigen, which is highly expressed in higher grade tumors and also metastatic disease, and especially hormone refractory prostate cancer. So, and also in very important is in the benign prostate hyperplasia, which is very frequently in old men, is not expressing PSMA. But for prostate cancer expressed, highly expressed this molecule. So this provides a basis for the theranostic of prostate cancer from molecular imaging to therapy targeting PSMA. And the Becca Hospital performed the first in-human study using lutetium PSMA and also some other PSMA ligands. It's just showing example of the efficacy of lutetium PSMA radioligand therapy. As you can see, this is a 77 years old patient with progressive metastatic castration-resistant prostate cancer and also bone metastases. This patient actually have previously treated by the orchiectomy and androgen deprivation therapy and abiraterone and also external beam radiotherapy. As you can see, this patient do have multiple metastases, and so this patient received 3 cycles of PSMA radioligand therapy. As you can see, after the treatment, this patient achieved a very good tumor response. This is another example of a patient was previously treated by the EBRT and also abiraterone and so on. But the patient have lymph nodes disappear, but unfortunately have disseminated metastases. Then the patient treated with 2 cycles of lutetium therapy, and you can see the patient also achieved a very good tumor response, almost a complete remission after therapy. So we have also seen some complete remission of even lung metastases. We know that a patient with CRPC and also visceral metastases, such as liver or lung metastases, has a very poor prognosis and worse outcome than the patient with lymph nodes or bone metastases. As you can see, this patient with lymph nodes metastases, CRPC, and also lung metastases. And this patient, even treated with ABRT and ADT and immunotherapy, still have a progressive disease. Then the patient treated with lutetium 2 cycles and 8 and 8.2 gigabyte respectively, and then the patient achieved almost a complete remission of these lung metastases. So even with a very specific group with a single kidney patient, we can see that after the patient, first the patient got a very good response with almost a CR of the lymph nodes metastases, and also very important is there is no nephrotoxicity for this group patient. And also very important is phase 3 trials, Vision trial with lutetium PSMA 617 last year published in the New England Journal. I will skip some details. And to the result shows that the lutetium PSMA-617 prolonged the progression-free survival and overall survival for mCRPC patient. So, and also the FDA approved this kind of radiopharmaceutical for the treatment of prostate cancer. So currently, the most frequently used compound of PSMA is should be lutetium PSMA-I&T and the lutetium PSMA-617. So both the physicians and also the patient may care about the difference of the different PSMA compound. So we start in a large cohort of 138 patients with mCRPC undergoing PSMA radioligand therapy with different PSMA compound, but under the same dosimetry protocol. As you can see, the lutetium PSMA-617 showed a longer half-life in all normal organs as well as tumor lesions, and lutetium PSMA-I&T have a higher initial tumor uptake. So the mean tumor doses were comparable for both lutetium PSMA-I&T and PSMA-617. So, and because this study also highlights there was a large interpatient variability in the dosimetry parameters. So just to highlight the importance of dosimetry. And within the ICPO, we also have many dosimetry training and scientific project within the ICPO. So although we are very satisfied with the outcomes with our previous data, we never give up because there is always improvement in medicine. So what about the advancement in theranostics? So first, the new roles, because we mainly frequently used in clinical practice, it's IV injection. And based on the gadolinium-labeled PET scan imaging showed that if we perform the IA intraarterial injection, we can achieve up to 3.75-fold higher as compared to IV injection. So we performed intraarterial PRRT. As you can see, first, the intraarterial PRRT can be more effective, and also for the patient with liver metastasis only lives longer than the patient with extrahepatic disease after intraarterial PRRT. So the next new indications, I will give several examples, because currently for the PRRT has demonstrated remarkable success, as mentioned in the management of neuroendocrine tumors, and mainly in well-differentiated G1 and G2 nets. So limited data has been reported on PRRT in G3 nets. So we have published two publications on G3 neuroendocrine tumors. So as you can see, by using PRRT, we can achieve median PFS of 10 months and median overall survival of 20 months, which is shorter than the G1 and G2 neuroendocrine tumor. However, if you compared as the same baseline characteristic patient of G3 patient, the results were very encouraging, because if you use, because in the Nordic study, for patients receiving first-line chemotherapy, there's only a PFS of 4 months and median overall survival of only 11 months. So we achieved almost twice longer PFS by using lutetium PRRT. And also for other indications, we use the PRRT in some other types of cancer, such as the thyroid cancer, including the non-radioiodine differentiated thyroid cancer, and also MTC, the thyroid cancer. So also based on the basics of the high expression of the somatostatin receptors in these two types of thyroid cancer, as you can see, even the patients are non-radioiodine uptake, this patient also have a very good expression of SATR, so which provides the basis for the treatment. And also, this is example of a patient with MTC. And as you can see, after treatment, this patient achieved a very good tumor response. And also, very important is the patient can achieve a survival benefit after the treatment. So another indication, like the NPC, as I think Dr. Yan has already mentioned, that it's very frequently occurred in Southeast Asia and including the Singapore. So for the end stage or advanced metastatic nasopharyngeal carcinoma, this just showing example of a patient which have failure to other treatment strategy, including the ABRT, the chemotherapy, even the PD-L1 checkpoint inhibitor, and other treatment. So as you can see, for this patient, it has multiple liver metastases. So the patient received the combination of IV injection and AA PRRT with different radioisotope for PRRT. After 4 cycles, as you can see, there is a very good tumor response for this patient. And also next, advancement for the new ligands. So first, as within the 2 decades, the most frequently used in the clinical practice is SATR, somatostatin receptor agonist. So recently, evidence has shown that the antagonist target more binding sites on the tumor cell as they bind to the somatostatin receptor independent of the activation site of the receptor. So for some years ago, it's mainly used in the Balbeca Center, led by Professor Baum, use antagonist the GI11. It is first in human study by using the gallium-labeled GI11, which is somatostatin antagonist. And later we use Nodaga IM3. This is another somatostatin antagonist. As you can see, as compared to the agonist, Dr. talk, by using the antagonist IM3, due to the higher tumor detection rate, and also very important is the very low liver background, which allows the detection of more additional tumor metastases, especially for the liver metastases. And also what is very important is for the therapy. We performed the first in-human study of a novel somatostatin receptor antagonist, lutetium IM3, for PRRT in patients with advanced metastatic neuroendocrine tumors. As you can, we performed the treatment in 51 patients. As you can see, a total of 90 PRRT cycles of lutetium IM3. We found the results showed that by using antagonist, we can achieve a higher tumor uptake and a longer half-life, which result in the higher mean absorbed organ and tumor doses, which is very important for the treatment of patient. This shows example of a patient with gallium dotatate. As you can see, we cannot detect the tumor obviously, and also FDG PET. However, with gallium dotatate IM3, we can detect a lot of liver metastases, and then we treat this patient by 4 cycles of lutetium IM3 with a total of 25 gigabake. And after treatment, you can see the patient achieves a very good tumor response. And also, we can perform intraarterial PRRT with SATR antagonist. For example, in this patient, the treatment is was very successful. As you can see on the right side, the patient achieved almost a complete remission of the treatment. So what about other peptide? One example is albumin binding EBTATE, we analysis the safety, pharmacokinetics, and dosimetry of long-acting radiolabeled somatostatin analog, lutetium epitate, in patients with neuroendocrine tumor. And this is actually originally developed by Professor Sean Chen at the National University of Singapore. And for lutetium epitate, it's we conjugated the ultra-tight peptide, which can target the tumor cells specifically, and then we use Evans blue moiety, which use endogenous albumin as a reversible carrier to effectively extend the half-life in the blood and substantially increase the targeted accumulation and retention within the tumor. Then we have the conjugated to the radioisotopes. So as by using the epitate, it showed a 7.9-fold increase of the tumor retention as compared to the Tate. So this shows just showing example of tumor response in patient after lower dosage of lutetium epitate. 3 months after the treatment, the patient achieved a good tumor response, treatment response. So, by using lutetium epitate, it has great potential to be to treat the patient more effectively or to achieve the equal therapeutic effect, but with lower dosage or with less frequency to the patient. So the last target is actually the FAP, which is actually a very hot topic recently because FAP, fibroblast activation protein, is highly expressed in 90% of all cancer types. So it was called or represent a pan-tumor target, and also a very hot topic recently. So the FAP for imaging, we mainly use FAP PET, gallium-labeled FAP PET. It has a very super promising result by using FAP PET for imaging in different types of cancer, such as almost 30 types of cancer. For example, in breast cancer, the colorectal cancer, pancreatic adenocarcinoma, or even CAFs, prostate cancer, sarcoma, and so on. So very promising by using FAP PET for imaging, or which has already shown many advantages as compared to the routine FDG PET. However, for this small molecule based on FAP-based tracers, reviewed a very short blood half-life and early tumor washout and correspondingly very short tumor retention time, so thereby limiting their therapeutic potential when conjugated to longer lived therapeutic radioisotopes such as lutetium-177. So actually, if to move on to the therapy, this small molecule needs to be modified. So the first strategy, we use lutetium EB-FAP, which is also originally developed by Professor Sean Chen at National University of Singapore. As you can see, by using the Evans blue moiety, the EB-FAP, the tumor the tumor uptake increase over time, as you can see at 20 in the preclinical test. At 24 hours, it has a significantly high tumor uptake and has a long tumor retention time up to 96 hours in your 87 tumor-bearing mass. And you can also see that by using EB-FAP, it has in another mouse models showing better uptake and FAP binding affinity as compared to the FAP-02, which is a very promising result. So based on that, we have performed the first human studies in China as well in Xiamen. This is led by the Xiamen Hospital by Liu Chen. And also there's upcoming clinical trials, the phase 1 clinical trials in Singapore to recruit the cancer, different solid cancer patient to participate in lutetium delta EB FAP study. So this shows the example of a patient with thyroid cancer with a lot of tumor metastases, as you can see here. So so after the administration of lutetium delta EB as you can see, there's a good tumor uptake, and also very important is a very long tumor retention, up to 168 hours post-injection. And this is shows 8 hours after the first cycle of lutetium EB FAP for this patient. As you can see, there's reduced radiotracer uptake and also reduced tumor cells, and also the symptoms of this patient has been significantly improved. So another strategy is you can use the FAP peptide. So we previously published the first result by using lutetium FAP 2286. As you can see in this patient with breast cancer, as you can see, there is significant tumor uptake since from 15 minutes until 10 days with very good tumor uptake and retention, which provides the basis for the treatment response. This is this compound also performed in other centers. And this actually provided by the Southwestern Medical University with treatment the patient by using lutetium FAP 2286. For this patient, 200 millicurie, and after treatment, as you can see, there's a very good tumor response. This is a lung cancer patient, and this patient cannot tolerate it with other chemotherapy and other treatment, but showed very good tumor response after FAP treatment. So we can also use other FAP peptides, such as 3BP 3940, because some advantages of this compound. We can use it for the PRRT with different radioisotope, with lutetium-177, yttrium-90, actinium, and the combination of the radioisotopes for tandem PRRT. And this shows just some experience. We have already treated the patient for pancreatic adenocarcinoma and prostate cancer, and also ovarian cancer, so many types of cancer, breast cancer, or oropharyngeal squamous cell carcinoma, esophagus cancer types, and some other very rare types. And just to show example for even the pancreatic adenocarcinoma, which has very poor outcomes. And for this patient, as you can see, after the combination of lutetium and actinium PTRT treatment, this patient, although has failure to the previous lines of therapy, this patient showed a very good response to the combination radioisotope tandem PTRT targeting FAP. So another I want to talk is strategy for the FAP treatment is developed dual targeting, actually is a FAP-RGD heterodimer. As you can see, by using the dual receptor targeting FAP-RGD, you can see we have a high, this is FAP-RGD imaging, which is higher than the RGD, which is higher than the FAP monomer. So because this compound can be used for imaging and therapy, we have performed some imaging studies. And as you can see, there's the advantages as compared to the FDG PET, and also has some superiority as compared to the FAP monomer in several types of cancer patient. So what is very important is as you can see for this lung cancer patient with multiple metastases, it has good tumor response uptake immediately after 15 minutes, and also at 1 hour, 2 hours, 3 hours with increased SUV max. And also for this dual targeting heterodimer PRRT due to the dual receptor targeting, and also the improved PK for this compound, which also led to a new hope for the radionuclide therapy in different solid cancer patients. So last I want is a new radioisotopes for because the alpha therapy, which is also a hot topic recently, because the alpha particle, as compared to the beta particle, it has a higher linear energy transfer and also can highly probability of DNA double-strand breaks, and also have short range, which can reduce toxicity in some sensitive normal organs. So this is just to show example of a patient who has refractory to beta emitter lutetium PSMA radioligand therapy, but after the tandem PRRT with a combination of lutetium and actinium, this patient still can achieve a tumor response. And also for neuroendocrine tumor patient, this is a patient that have received 11 cycles of PRRT. This patient have previous response very well to the lutetium dotatate and dotatalk, and also achieved very good survival after multiple cycles of PRRT. However, after latest lutetium dotatalk 2 cycles, this patient had a progressive disease, and also after the even yttrium-90 dotatalk, also progressive disease. But for this patient, as you can see here, after 1 cycle of actinium dotatalk with 10 megabecq, this patient had a tumor response. And also, we also published some other patient with alpha which has beta refractory, but response good for the alpha therapy. For example, this patient had a progression disease after beta radioligand therapy, but can also respond very well for the alpha therapy. So for summary, for the lutetium PRRT and PRRT have been paradigms for theranostics with radionuclide theranostics. So new strategy on the radionuclide theranostics, including the development of new indications of theranostics, the combination therapy, validation of new targets, optimized pharmacokinetics, new ligands, and also new radioisotopes. It's a personalized and targeted molecular radiotherapy, which is tailored to the individual patient in precision oncology. It's moving from innovation to implementation in the real world for the treatment of cancer. And finally, I'd like to speak a little about ICPO, International Centers for Precision Oncology, which is a growing global community in precision oncology, seeing the emergency need for broader international collaboration, standardization, training, and implementation of specialized medical infrastructures, a group of medical and scientific experts, and also international philanthropists, patients, and financial supporters have come together to fund the ICPO in 2019. So we have learned some targeted molecular precision oncology, which utilize as molecular and used to deliver precise and highly localized diagnostic imaging and therapeutic agents to the tumor cells. And in targeted imaging and therapy, radioisotopes are coupled with targeting molecular to enable high technology imaging tumors such as PET-CT, SPECT-CT, or deliver beta, alpha, or Auger radiation to tumors. So the cancer patient is considered as an individual who should be provided with personalized targeted therapy. And so the ICPO Foundation's main project is to foster communication between patients, medical experts, industrial and governments, and to build an international community bringing precision oncology and targeted isotope imaging and therapy. So the ICPO Foundation objective, including the global community in precision oncology, the Academy for Precision Oncology, and also the supporting science and technology development, and also established ICPO reference and training centers. So this is actually the Academy of the ICPO, led by Professor Dr. Richard Baum. And also we have also the Scientific Advisory Board. I'm also working for them as Dean of Research to contribute to for the supporting scientific and also new technology development for precision oncology. So the most important thing is the benefit of the patient is the highest law, which is also the mission statement of ICPO. So finally, I want to thank many national and international collaborators for the very nice collaborations, and in particular to Professor Richard Baum, and also the ICPO Foundation, and also my DDR and CERC at National University of Singapore team, and Professor Peklan Kong and Sean Chen, and also many other colleagues. And thank you very much for your attention.
Thank you, Dr. Zhang. Oftentimes, a presentation which is very broad doesn't go very deep. You did both. You've gone very deep and also very broad. We're on the journey of hope, and the hope is that these targeted therapies can be applied to all cancers. Do you think that's a realistic hope?
Yes, exactly. Yeah, I think because we are working for both the scientific project and also for the clinical translation, and also for we hope many radionuclide theranostics approach can be applied very soon to the clinical practice and to more and more cancer patients to achieve this.
That's my follow-on question was, the journey of hope is a journey, and clearly some of the things that you're sharing with us are very far upstream in the lab. How long does it take to bring some of these therapies to the clinical setting where they can be offered to patients?
Yeah, I think there's already, this is journey of hope, but we're still on the way, and I have also present some approach which have already from the innovation to the implementation to the real world. Actually, no matter in the trials or in other ways for the studies, it has already shows the benefit to the patient, and I think it's already we have already the implementation in the real world, and we hope we have more approach in this field.
Thank you for everything you do for the patients. I know that from the clinic, you probably feel very far away from the patients, but I want you to know that the patients really appreciate this work.
Thank you very much.
We're now going to look at this new therapies from the patient perspective. And as you know, I'm a patient advocate and leading the CNETS group here in Singapore and around the region. But I wanted to introduce two additional patient advocates who are doing great and noble work and in somewhat different areas. So Andrew So is the department head for volunteerism and community outreach for the 365 Cancer Prevention Society. We shorten to 365 CPS. He has a large and very active group here in Singapore, and they have frequent activities practically every weekend for patients. So welcome, Andrew. And then Aparna Mittal is the CEO and founder for PatientEngage. This was originally a group established in India. Our partner is living here and residing in Singapore, but the large body of patients that her group is addressing are mostly in India. And so we wanted to bring that perspective as well. As part of the reason for choosing this afternoon time slot is so that our colleagues in India can join the webcast this morning. Let me ask if we can begin by each of you sharing briefly about your group.
So I'd like to acknowledge patients who step forward for things like clinical trials, because without them, we would not make progress in this journey of hope as well. As much as the technical guys and the clinicians and the researchers do their bit, more and more we see the value of patients. A little bit about PatientsEngage. PatientsEngage is an online platform focused on supporting patients be better informed in managing chronic conditions. And we do believe that the better informed they are, the better choices they make, and they can contribute and effectively participate in shared decision making along with their healthcare teams. And we cover, as part of PatientsEngage, a wide range of conditions, I think more than essentially chronic conditions, and dealing from a range from, autism and diabetes to cardiovascular, neurological cancers, etc., rare diseases, and so on. So it's a wide range. The reason for that being that we believe that people are not just dealing with one condition, they're dealing with often many conditions. And they should not need to go to multiple different places unless they really need specific information. Large numbers will not need to, kind of get that specific stuff. Also, at least they should have a gateway to be directed. So we do direct people to specific groups like yours, Bill, for instance, whenever people are looking for information. It's a very content-oriented platform which focuses on, again, both the opinion of professionals, be it healthcare professionals, supportive care experts, and so on, but also lived experiences of people, both patients and their family caregivers.
Well, thank you very much. Yeah, so mostly it's an online group.
Mostly it's an online group. It's a website plus social media, YouTube, so multimedia content covering all of those aspects.
And Andrew, why don't you share with us about 365 CPS and specifically your activities as a community-based group?
Sure, thanks, Bill. It's my pleasure. And thanks, Bill and the team and everyone at CNETS for having us here. I think it's both a pleasure and an honor for 365 Cancer Prevention Society to be here today and to be involved in this particular event. So 365 Cancer Prevention Society has been in Singapore for the past 19 years. Next year is our 20th anniversary. And it is a IPC status charity organization, and we provide holistic support for all cancer type patients, past and present, and also their caregivers through both psychosocial and also the physical aspect. We currently now have 4 social service centers island-wide at Tampines, Ang Mo Kio, Bukit Panjang, and also Clementi to support patients in their journey against cancer. So that is also in line with our society's trifold mission of cancer education, cancer prevention, and also cancer fighting. So we are now about more than 1,000 membership strong, and all cancer patients do get access to our whole list of activities and services, from counseling to dietetics to even physical activities, complimentary and free of charge. Right.
So you can see that that's very different structure, right? It's on the ground with the patients. And we'll talk a little bit more about these different types of support that can be offered online and in the community. I would say that for CNETs, we also have physicians who are members of our society. So we're run as a society, and we have two classes of membership. The ordinary members are patients and caregivers, and the professionals are those from the clinic or general healthcare providers. Could be people in research, could be clinicians. And by bringing those two communities together, we offer opportunities for discussion about these new therapies and access to therapies and things like that. One way I wanted to connect the interesting talks that we've heard with the patient perspective is that many times we hear from patients that, why didn't I know about this therapy before? Like they got misdiagnosed or they got late diagnosis. And they wonder, how come my physician didn't tell me about these new therapies that are available? And this is kind of a missed opportunity. And one of the ways in which patients and their caregivers can bridge this gap is through patient organizations. And so I wonder if we can just go across and talk a little bit about this, how the different groups make patients aware of what are the new and emerging diagnostics and therapies.
Right. So I think there is the misdiagnosis and late diagnosis. What we also find is sometimes in certain markets, because financial access is a challenge, doctors will often make the choice of whether they should even talk about a certain treatment option that may be outside the paying power of that patient as decided by the doctor. However, we do still believe that it should be a joint decision and it should not be just the doctor's decision. So we do make sure that we put out content on our platform to cover the latest options, just so long as they're already available and not in a in too early a stage. And not.
Do you have information on trials?
So we're not listing clinical trials, but we are helping patients search for clinical trials if it's available in the country. In specific cases, we've also helped them look for, or at least tell them that, where they can go to look for information. But definitely on therapies that are already available in a country and or even in the neighboring countries, we do talk about it and write about it. And if there are experiences of people who would like to talk about it, then we share those experiences as well on the platform. So we do make sure that people are aware of the options available at all times.
Andrew, do you encounter this remorse that patients may have or family caregivers may have that, why didn't I know about this test or this treatment?
I guess with the current so-called virtual information age, there's so much of information and so-called content that's available. So as part of our so-called advocacy in terms of educating on cancer, we has actually started a resource and research center, and in fact, a team that's hopefully to able to create a certain content that is more simplified for the man on the street. While at the same time, on our weekly and in fact daily basis, we continue to advocate for more education to cancer patients, especially our members, and also to the community through health talks and working with different medical partners, be it pharmaceutical companies or private medical centers, to turn out information and also contents to the community so that they are better educated. But of course, there are certain areas which is very much still work in progress. Like for example, patients will tend to tell us that, hey, there's just not enough face-to-face time with the doctors, or doctors simply see me like 5 minutes and then that's it, next patient. So we do understand, talking to doctors, talking to some of our medical partners, that it is a juggling act, especially now with more things opening up. Doctors' caseload has also increased tremendously. And they are also facing a lot of challenge, like sometimes patients felt that they are more knowledgeable than the doctors or the medical staff. So it is a balancing act. So all we can do as an organization is to manage some of these expectations, while at the same time, getting support and also help from external parties to better mitigate such feedback or such challenges.
So broadly, there are two different kinds of patient support groups. One is the kind of Facebook groups, the online groups, and they have a role. And then the other is the community-based group or regional-based group, where you have an opportunity perhaps for face-to-face communications. Let's talk a little bit about the strengths of each. So if you were looking for information on medical therapies, want to know what's the latest for a particular illness, my experience is that going to the larger groups on Facebook or other communities like Patients Like Me or others, Smart Patients, there's a lot of such groups. They're more or less discussion groups, and they tend to surface all these new therapies that are available that are coming out of the clinic, out of the lab and going into clinical trials. And also in some centers in Europe, Dr. Yan said that when they look to bring therapy into the community in Singapore, they look first to Europe and North America to see if it's already been tested out there. So these online groups would have access to that information, would be a first point of reference to find out what's available. And you can get into this discussion in those groups semi-anonymously. So you don't have to go to your community and say, oh, I have cancer, I have this, or I have that. You can semi-anonymously join these groups and participate in such discussion. Would you agree with that? You're running such a group.
Yeah, you're absolutely right that, the larger groups allow that flexibility and access to that. In addition, some of them also have, networks with researchers. For instance, we actively work with the medical community and healthcare professionals, and we reach out to them for specific queries if a patient has raised, and they will advise us or let us know what they may not tell at an individual consultation, but they will guide us to refer those patients to the right people. We also use, there are some patients who are able to navigate that, but otherwise work through platforms like ours or like these, which then leverage platforms like Twitter, because actually Twitter is also another very good source for medical information, but you really need to know how to navigate that.
It's a really good search tool if you know how to use that tool.
Correct. So, or, if you follow the right people, for instance, you get a lot of good content. So we kind of play that conduit for the community that follows us so that we can, because also we have to realize that a lot of this information can become overwhelming for most patients. And
so discriminating and sifting through is a challenge.
Correct.
And that kind of can bring back to the community for, clarification. So maybe you can talk a little bit about that. Patients sometimes go to the community simply because they're lonely or they want to meet another patient like them. But sometimes they want to verify what they've seen online.
So for us, there's always informal sessions like Kopi Chat, where like-minded cancer patients could hang out, be it virtually or physically, to talk about their problems or even about their particular so-called diagnosis that they can share. So we try to take some of this feedback or issues that they have raised to some of our medical partners to actually verify and at the same time, consolidate some of those contents or information for them. At the same time, when we do community health talks, like some of the more advanced therapy or even treatments like CAR T cells therapy, We also collect feedback from the so-called audiences, as we always do it on Facebook Live on Saturday evening. Some can be very personal, and some are a bit too general. And some of these questions actually come from audiences around the world, especially within the so-called neighboring countries. So we try our best to address most of this, right, with the speakers or with our medical partners, and in turns disseminate some of this. At the same time, we also collate a collective so-called content from all these different sources that we receive, so that it could, be a bit more consolidated and presented it on be it our social media platforms or even on our websites.
Do you give any advice to patients? Do they come to you and say, which doctor should I see, or which treatment do you think is better?
From our perspective, we try to stay neutral, unless it's something that is very specialized, as what I mentioned earlier on, like CAR T-cell therapy, which currently both SUH and NUH is currently fronting it. In fact, from what we understand, some of our private cancer centers, like Icon Cancer Centers that we are working with, is not even into this. So it's very hard for us to pinpoint what kind of referral, but we do get queries on that. Sometimes a particular doctor from a private practice or private cancer centers speak on certain topics, and the audience would ask for the contacts or even the references, but most of the time we would ask them to inquire with the medical center itself rather than that particular doctor, because they may have their own preferences or also their workload, right?
This is quite a sensitive topic because I'm not a physician, and I don't think any of us have medical training. So if we give advice, it has to be seen as sort of one patient to another. As a patient, I could tell you, I've been through PRRT, and it really benefited my case a lot. And I've seen a lot of patients come through our group who've had the benefit of PRRT. And like 80%, 85% of them actually have derived benefit from the therapy. So if you're an eligible patient, I would recommend that this is a good therapeutic approach, right? So this is something that in CNETs we experience a lot. Patients come with questions. They've been misdiagnosed, late diagnosed, and they want to make the next step really work. And so they're asking, should I go for surgery, or should I go for this targeted radiotherapy or something else? And we do offer this advice, but in the context of, please check with your doctors. And typically the first question they're asking is, which doctor should we see? So for that, we often have to look at their medical history and see, is surgery probably in the roadmap for them, And if so, then maybe refer a surgeon. If it's more of an oncology question or a nuclear medicine question, we refer to others. So this is kind of judgment call, and at least in our group, we go a little bit more towards giving this advice. But at the same time, we try to empower the patient to own their data, to collect their CD from the imaging department. Sometimes in neighboring country, they're not very sophisticated about this, and the hospital will say, I'm sorry, we don't sell the CD, or we don't have the part number, or things like that. And the patient doesn't realize they actually own that data, it's their data. And so they should say, whatever it takes, I need to buy that CD. And when you have that CD, of course, you can go and get second opinions. You can send it to SGH Nuclear Medicine. They can look at it and then tell you, whether kind of lead you in terms of the diagnosis and what the treatment options are. The other thing that we do is we help them organize their patient records so they can present to a physician. And so the patient will come sending images by WhatsApp or whatever, and what we'll do is we'll put them in chronological order and package them together with a brief case history so that a second opinion in Europe or here in Asia can be easily sought. And I wonder if you guys have similar types of engagement with patients?
So we don't typically sort their data. We do tell them what they should look for in their data. So we will advise them to, and sometimes we will help them understand their reports as well, because some of them will not be able to. They don't know where to look for what in that pathological report. The challenge with some of our patients in a country which is larger, India, is also that they're figuring out whether they should go to a different city or different part of the country. And again, on that, we then have to help them ask the right questions as to whether it's worth traveling very far or going only for an online second opinion. So with technology now, we are advising a lot of patients to at least get an online second opinion from the key cancer centers, for instance, if we're talking of cancer, and not invest in traveling up front. And also on the whole second opinion thing, our question always to them is, you need to be very clear what it is you're trying to find out, right? So often they are not clear. They just want a second opinion, a third opinion, and there's no end to it. So what we try and get them to think about is what is it that they're trying to address with these questions, and therefore who should they be talking to? Because even in cancer, is your next person a medical oncologist? Is it a radiation oncologist? Is it a nuclear medicine specialist? Is it
So
surgeon?
yeah, now we're getting to the issue of empowerment,
Right.
right? And before we go there, let me just summarize that the local support groups can provide fellowship. They can provide some degree of face-to-face consultation. You can meet other patients and feel less lonely, participate in social activities, and generally get a sense that you're on the right track. You're in touch with the right folks locally.
Correct. And you can probably talk to also people who've been through similar journey. So, as you said, you can put in touch those patients with somebody who's already been through PRRT, right? So that, I think, is also one of the things we find, that specific treatment protocol helps for patients.
But I think the really invaluable lesson here is that, especially for the newly diagnosed, they may not be ready yet to join a group. So then they can go online to a group where they're semi-anonymous and they can see the landscape. But again, there's the filtering part. So we come back to what makes a smart patient and how can we empower patients to be smarter?
Is there such a thing as smart patients? Because I think generally all of us think that we are smarter. I mean, it's just like when we are a staff, we always think that we are smarter than our bosses, right? And likewise, I think for us, we, just to add on to the earlier question, we get a barrage of questions. I mean, we have a team of, care leaders that do one-on-one support with patients. They get questions, anything from, should I be taking supplements? Should I be looking at alternative medicines, right? Or TCM, things like that, to financial assistance and so on and so forth. So, I mean, my team of care leaders, they are really, I applaud them. They are really like jack of all trades. They really need to know everything under the sun. For those that is too medically inclined, then you will have to surface it to some of our partners. Now, personally, myself, I volunteer my time for the past almost 5 years now with SGH hematology stem cell transplant patients as a patient peer supporter. So, I mean, I got my bone marrow transplant like 12 years ago here in SGH. But I mean, when patients now, decides to go for a bone marrow transplant, they will ask me, what's the journey like? Is it going to be painful and things like that? With the advances of technology, I mean, just like what you said, Bill, I may not be able to relate, to the same pathway that they are going through right now. And that is where I think groups needs to also constantly upgrade themselves and update themselves so that they are aware what are the development. So as a group here in SGH, and which I'm part of, we have this continuous learning where we get different medical and healthcare professionals to update us and tell us what's the latest, what's the happening around certain technologies, treatments, and the kind of support that patients would actually have. If not, and
Not only that, for the advocates, right? The advocates also need to keep abreast.
Precisely. If not, it's all talk and it's just like, hi, bye, how are
Yeah.
you, okay,
Yeah.
you know, take care of yourself, get well soon, things like that, which are very surface, right? So
Yes.
I think patient support groups or advocacy groups needs to, you know, go more than that, right? To really provide that deeper support.
Okay, let's close by talking a little bit about participatory medicine. So a lot of times the patient sees the white coat and they just sort of blindly do whatever the doctor says. Not that that's bad advice, but one needs to be engaged in the conversation. And I think healthcare in the US and Europe is going more towards take good care of yourself first. Don't wait until it's really bad and then you end up in ER or something like that. So this requires a certain amount of knowledge, a certain amount of empowerment for the patients, and it becomes a kind of dialogue with the physician. I know my medical oncologist, he and I will kind of debate my case as if it was a third party's case. You know, what would you do in this circumstance? So I wonder if we can just comment on what is participatory medicine and how do patients avail themselves or grow themselves for this?
Yeah, so that's a hugely complicated topic at the moment because I think to large extent there is information everywhere, which means that even healthcare professionals are struggling with the kind of questions patients are coming up. What we need to do somewhere as even patient advocate groups, etc., is help patients become those smart patients so that they're asking the right questions. There's never a wrong question, but there are more effective questions that they should probably be asking so that they get the right answers from the doctors in the limited time that they have with doctors, right? So I think that's an area that we all need to, the entire, the healthcare system as well as the patient advocacy groups or support groups need to handhold the patients to get there. On their own, I think patients, some of them will kind of find their way, but others will really struggle. And the other thing I think, which I always say, is for a lot of chronic disease management, large parts of care is happening outside the clinical arena. So unless they are actively involved and they buy into that conversation that they have with their doctor, or they understand it completely and they, kind of reach that shared decision and participatory medicine, as you called it, when they leave the doctor's clinic, what they take back is always a subset of what has been discussed. So that conversation, therefore, is increasingly more important if they have to take it back to their homes and be able to follow through till the next consultation comes back.
Do you have thoughts about participatory medicine and how patients can be more empowered in that dialogue?
I think, Bill, that's a balancing act between the patient and the medical professionals' relationship. I mean, it's all about relationship building. If the medical staff or the doctor feels that, hey, this patient seems to be overly smart by asking too many questions and requesting for too many tests or diagnostic screening that is not necessary, I think straight away that person will write the other person off. And likewise, if from the patient's perspective, they find that my doctor doesn't have good bedside manners and all, similarly, it will be a total comms off, right? You talk about the white coat thingy. I think very often as patients, we come across, many of us going to a medical facility, we suffer from this white coat syndrome. Even for my case, I go in, the first thing we do a triage or some of those, body checks like blood pressure. Straight away, my blood pressure goes up. And then the nurse says, hey, why is your blood pressure so high? So we get distracted. I mean, the next thing when the doctor says, hey, your blood pressure is high today. So the conversation moves to your blood pressure instead of your real problem. So my advice to fellow patients always is write down. It's just like when you decides to go into your boss's office to ask for pay increment, write down, your objectives, your points, and then make sure you run that through. And don't leave the office, unfortunately, or doctor's office without getting all those questions answers, or having your doctors go through that with you. I think it's good that all of us, should be empowered and take charge of, our own medical health. I still do ask for, my FBC results. I mean, the printed copies nowadays, even MC is soft copy. I mean, for us around this age group, I think we can still manage it. But for the elderly, there's a lot more that's on their mind. Some of them having chronic illnesses too, right? And worrying things like medication safety and so on and so forth, or even their own livelihood. So there's a lot of things going through their mind, and it's very difficult for them to focus and to say, I come into the doctor's office, right? This is what I need to know about my own illness, because a lot of times patients, whenever they have a medical appointment, they waited so long outside the doctor's office or at the clinic, they're really very frustrated, they're really stressed out. So by the time they go there, they get in, they just want to get out, right? Because nobody wants to spend like a couple of hours at the hospital, at the clinics, just waiting. So I think we need to slow down, and we definitely need to teach all these patients and say, please slow down. You need to look at this, with a certain urgency, because you don't get to see your doctor every day. You only see it like 6 months or once a year. So that is really a golden time that you need to capitalize on.
I agree with you, Andrew. And I think one lesson there is to kind of, maybe it's for the caregiver to go along and set aside their emotional concerns, but just focus rationally on what are the options that are available. And I guess to keep in mind that if you go to a surgeon, they're likely to be considering surgery first. Go to oncologists, they're likely to be considering chemo and biologics first. And so consultation is much more affordable than change of therapy. You should get the consultation first and then decide on therapy. So unless you have any final words, I'll bring our panel to a close.
No, I think, thank you. I think, as you said, it is important for every patient and their family to make that effort, to go prepared, to find online platforms or community groups, or either niche or larger groups to help you navigate through this journey and to not feel alone.
I think for me, my word out to patients is to take charge of your own medical journey, be it treatment, diagnostic, or, you just have something on your mind, do take charge of it and find out for yourself, do your research, do your homework, and talk to the medical professionals. For those who are in the patient support groups and all, don't be too quick to share your story, your journey with a new patient that comes to your group, wanting to be part of it. But I think you should spend also the time to really understand that particular patient or that new member, and also develop a strategy how you can help this person. This new member could be a bit less savvy on the medical part of it, then that's where your role could actually come in. And at the same time, work with medical professionals so that you uptake your own knowledge and your group's capability, so that you can provide that holistic support to whichever the members that's joining you, while at the same time also working with community groups like a charity like 365 Cancer Prevention Society, because those organizations do provide you with the physical infrastructure to further extend your reach of your group, while providing you the space and also the resources, right, to better serve your group members.
Thank you very much. Please join me in a round of applause for the panel and Aparna and Andrew and the wise words that we've heard this afternoon.
Thank you.
Don't go away, but if you want to stand by or something, I have some gifts. Jing Jing, please join me at the front. Yeah, Jing Jing has been my colleague through organizing this event. And you have, what is that? A bonsai for? Okay. So, Dr. Sean, we want to thank you very much for your presentation today. It was really insightful and introduced the program for us. And I will just explain a little bit about why we chose to provide a bonsai to you. Because bonsai is symbolic of vitality and long life. It's very hardy, but you must take good care. And this bonsai comes from a local company called Bonsai Inc. And they cultivate these bonsais. The original plant comes from Japan, most of them, some elsewhere. And so I give this gift to you. Some instructions are here for care and love.
Thank you. I enjoyed this session. I think in this world, coming down to a patient care, doctor alone can't do anything. We need to unite all the people in healthcare, patients, patient advocates, family members, caregivers. Only in this way, the patient's life will be like this bonsai, will be green forever. Yeah, and thrive. Thank you.
Thank you so much. Jingjing, the next one. This will be for Dr. Zhang. About these plants, they come from a company, Bonsai Inc., here in Singapore, and it's a beautiful showroom. And there you can find plants of all different size and shape, and each one is lovingly maintained. So they're like totally unique. You think of trees, right? They're all kind of identical, like you go to the forest. But like us patients, each one is completely unique. And so this is a very special. This name is, what name is this one here? They have a name, each one. I don't see it here, but anyway, thank you so much.
I really appreciate and I also very enjoyed this webinar today. It's really an impressive platform for from the CNAS Singapore, and also communication between doctors and patients, and also for I thank you so much, Mr. Bill, and many thanks to also the friends. Okay, thank you.
Two more small gifts. Aparna. This one is what's called a cascade, where the branches appear in layers, going lower and lower. This one almost below the planter box. Also, you can see that there's two little characters meditating under the tree there. So it's like a little cinematic set. And I hope you keep it next to you, and you can observe it, and it'll bring peace and calm to you throughout the day. This is hibiscus, right? Yeah. So, Andrew, there you are. It looks very wise, right? It looks like it has real character.
Thanks. I think it fits perfectly at the office.
Okay.
Thank you, everyone. Thanks, Bill, for having us here once again. Thank you.
Aparna, anything?
Thank you. Thank you. I think the bonsais are really a great symbol for Journey of Hope. And thank you for such a thoughtful gift, but also more importantly, for this session, which has been extremely incredible. Thank you.
To vitality and long life, longevity. Thank you to Bonsai Inc. Okay, so that's the end of our program. We have a lovely tea and coffee outside, snacks, savory and sweet. Please stick around. You'll have a chance to talk to Dr. Yan or Dr. Zhang if you want, and to our patient advocates. So thank you for your attention, those of you who are watching on this webcast. And we thank you very much for attending this program today. It will be available as a recording for you to play back later.